will be in a panel in 45 minutes to discuss various aspects regarding all controversies and how to apply these challenges of guidelines in our locality. Of course, we have Dr. Iman El-Gindi, a professor of obstetrics and gynecology at the Kazig University and the current president of IFRI, and my professor and mentor, Dr. Hassan Maghrabi, honorary president of IFRI, Alexandria University, and my colleague and friend, Professor Yasser Kassar, dear friend of mine, and of professor of obstetrics and gynecology at Alexandria University, and treasurer of the IFRI. Of course, Barbara Lawrence, our honorary guest today, and also we'll have Dr. Dua Gnena, professor of nutrition, Alexandria Medical Institute. Now we'll start talking about lifestyle modifications and weight reduction in this subgroup of patients. Dr. Dua, please, can you recommend what is the diet you recommend in PCOS patients, please? Dr. Dua, are you with us? Dr. Dua Gnena? Dr. Dua?
Move to the next question, Ashif.
Dr. Dua, are you with us? Okay, we'll move to another sector.
I think, sorry, Sharif, I think based on Reham presentation, now there is no special diet regimen better than, I think it would be based on the patient preference and their suitability. So there is no strict like all days, low calorie or high protein or whatever, all works, but according to patient suitability. I think this is what is, and I think this is from what we see in our practice.
If she comes back, let her answer the question again, please.
Okay. We'll shift now to ovulation induction first till she is available. What about the first line ovulation induction? I think that according to guidelines, these guidelines and the previous guidelines, letrozole is considered to be the first line ovulation induction agents in PCOS patients. I'll start with Dr. Iman, please. Your regimen in letrozole and the regimen and the number of cycles, please.
Okay. Dua is present.
Dr. Dua, are you here?
They didn't let her in. Green.
Dr. Dua,
nobody's in the waiting. I'm checking. Let me check again.
Yes, she's here, but she's muted.
She sent a message. She is muted.
Yes. She is muted. Sameh.
No,
Sameh.
she does not. She's screen here. She shares screen now.
Sameh, please.
هي عندها مشكلة يا دكتور في المايك بتاعها. الكاميرا بتاعتها شغالة اهي والصوت عاملاه unmute.
Complete until she comes back. Complete your shift till she comes back.
Okay.
We proceed, Dr. Sharif, I think.
Dr. Iman, regimen for letrozole induction and number of cycles, please.
I think with PCOS being a very common condition, all my aim is to be make the life of these ladies stressless as possible, because they are very anxious about don't having a regular cycle before marriage, about having problem upon marriage, etc. So we have to do it very smoothly. Counseling about, of course, before going for letrozole, about lifestyle modification, very soft between me and the lady in the first tilt here, 5%, like the old guideline would make a difference. And then I go for letrozole. Yes, I give letrozole as first line treatment. And this have been since long time ago. And I give it for 6 months. I give it first like 3 months. And of course, I do monitor in the first months and be sure that she take it from third day, 1 to 2 tablets according to her body mass index. And then I see her in the 10th or 11th day of the cycle. I check that ovulation is good and the endometrium is good. Everything is fine. I make very nice reassurance and I tell her, please go home and have regular marital life, the same regimen without even coming back. A main advantage in letrozole, there is no cyst formation like in the old days with clomiphene. So I take advantage of this, and I see the lady after 3 months for further reassurance, and then again I give a second chance of 3 months. With 6 months letrozole induction, I think this is a very fair a chance to go for very cheap a chance with the least stress. And here I can recall, if I'm talking about a study and to counsel our patients, this is interesting study by Amer in human reproduction a few years ago, double-blind randomized controlled trial, 6 months of letrozole versus clomiphene. 6 months of letrozole gives a cumulative pregnancy of 61.2% versus 43% for clomiphene. So I think this is fair and stressless for these ladies.
Dr. Yasser Kassar, please, regarding letrozole, do you use the same regimen, 2 tablets for 5 days, or do you have different regimen?
Yes,
And-
Sharif, I use the same regimen, 2 tablets per day for 5 days, and then follow up on 10th day or 11th day. I think that most of the female go well with this regimen. If I have no response with letrozole in some females, I may add some adjuvant if I didn't add like metformin, for example, or inositol nowadays. And if there is no response, I can shift to clomiphene citrate. Sometimes I have cases no response with letrozole, but they have response with clomiphene citrate. But with clomiphene citrate, I have to be very cautious with monitoring the female because there is more risk of ovarian hyperstimulation syndrome. There is more risk of achieving multiple pregnancy. So I have to be careful with them.
What about tubal testing? Yes, do you test the tubes before starting letrozole, after a few cycles, before shifting to second-line gonadotropin? When do you do tubal testing in this kind of patients?
If the female has no surgical history of any problem, or if she is not old age, I think I can postpone this till 6 months of full trial of 6 months of induction, and then I do tubal tests. But if the history going with something alarming, like if she had appendectomy, for example, especially if it was complicated appendectomy, or if she has chronic pelvic pain, I think we can do hysterossalpingogram first.
Professor Hassan, regarding the use of adjuvants, Yasser mentioned metformin, minostols, and the panel and the participants asked about dexamethasone and corticosteroids. What are the preferred adjuvants? Do you use adjuvants during ovulation induction? And what is your preferred type of adjuvants in this group of patients, please? Dr. Hassan.
Okay, this is a two-sided reply. One, according to guidelines, nothing is conclusive. Second, I think, as Nihal said, mitochondria is important in PCOS, and Q10 is important for electron transport along the mitochondrial complexes to keep the mitochondria healthy. So it has a role. I think it has a role, or for me, it has a role. Q10. Of course, we had old studies with N-acetylcysteine and metformin in adolescents and in adult PCOS.
So we used to add metformin to clomiphene citrate, but the guidelines didn't mention adding metformin to letrozole. What do you think, Professor Hassan?
I think they are the same.
The same. You mean it's you add
Yes,
metformin
yes.
to letrozole?
Yes.
For the sake of improving pregnancy, or just to correct the metabolic syndrome?
For better pregnancy outcome.
Better pregnancy outcome.
And you have to continue it mainly for better pregnancy outcome.
Okay. Is there still a role for clomiphene citrate? Yasser answered earlier that in cases that are resistant to letrozole, he may shift to clomiphene citrate. Professor Iman?
No, I don't use clomiphene for long.
You are not using clomiphene for
No.
long?
So if there is no response to letrozole, I have to make gonadotropin, to add gonadotropin. But it checks that hormones are adjusted, everything is okay, because sometimes in presence of hormonal disturbance, the response is not that perfect. Just you justify you adjust everything, it works great.
Dr. Barbara Lawrence, please. Do you think there is still a role for clomiphene citrate in PCOS patients?
No.
No. So
Ask her about letrozole also.
yes,
So I mean, we use, well, in patients who don't want to go for IVF, we start with letrozole because I think it also has a lower impact on the cervical mucus and on the lining itself. So when we go for hormonal inductions, then it's first letrozole, and if this is not working, then it's gonadotropins.
okay, thank you. Now we'll talk about gonadotrophins, protocol, dose, and number of cycles. We'll start with Professor Hassan. Gonadotrophins, protocol, and dose, and number of cycles as a second line management.
If 3 cycles of letrozole fail to get the patient pregnant and she is suitable as regards age and BMI, we can try sequential letrozole HMG. So you give letrozole for 5 days followed by low dose HMG for 3 months. But most important is, I think, the cost-effective study. Which protocol is cost-effective? To go directly after failure of letrozole to IVF or to letrozole HMG? And I would like you, Sharif, to ask all the panelists about this. What is the most cost-effective protocol? There are several studies illustrating this. So what is the best sequence? What is the most cost-effective sequence?
The cost effectiveness of letrozole gonadotrophins. So it was my next question. So we'll start with Dr. Imani Gindi. Do you have this intermediate step, which is letrozole gonadotrophin?
Exactly.
Yes, I definitely have this step. Most of our patients are young age, not married for long. I go very systematic, as I have already stated. I gave letrozole up to 6 months. It works great. If not, I go for gonadotrophin. I never do drilling. Gonadotrophin, oral letrozole with gonadotrophin, also it works nice. I do very close monitoring so that 1 to follicle maximum. I don't have many follicles. I don't have concern with careful induction and with low dose of gonadotrophin. I don't have any concern of OHSS or multiple pregnancy. So yes, I go for this second line. And if it doesn't work, I go for the third line.
Okay, we'll go to the third line later on. Dr. Yasser Kassar, do you go for letrozole gonadotrophins? And if you do that, what is the exact schedule? Do you start with letrozole and doing sequential, or you do overlap between letrozole and gonadotrophins?
Yes, Sharif, I go for this protocol, and usually I have this female before went with letrozole alone, and I saw the response if there's 1 follicle or more. So I have to be cautious. Usually I use letrozole 5 days, starting from day 2 or day 3, and then I add 75 gonadotropin unit per day and do follow up every other day till I reach the follicle size from 17 to 22. And usually I do triggering here and follow the case for occurrence of pregnancy.
Okay, perfect. I think now we'll have Dr. Dua is ready. Dr. Dua, are you with us? Dr. Dua, again, did you? Dr. Dua, again, please.
Sharif, can you ask till Dua gets ready? Can you ask Dr. Barbara what she thinks about the time to pregnancy? Is this important? And what is the most cost-effective protocol in terms of time to pregnancy, short time to pregnancy?
My honest opinion,
Yes, please, your honest opinion. We want just to get this hot a little bit.
But where Dr. Hassan? Dr. Barbara is in Emirates.
No.
Yes.
No. Let her answer.
her experience in Emirates.
Let her answer this question. Stop.
Well, honestly, I see this is the lifestyle modification. At least here in our population, it doesn't lead anywhere. So it's very, I mean, we have a few brave patients who really lose weight, but this is the minority. So in the end, we'll have to go for some stimulation medication. And as said, the patients here, they want to get pregnant yesterday. So they are not patient. I mean, this is something which is, of course, different from country to country. This is what I'm seeing here. So they are more than willing to go for IVF. Also, of course, here they are covered by insurance, which is a different point, which of course has to be taken into account. But this is just as a perspective what I'm seeing here in Abu Dhabi. But still, I think it's a more effective and a faster way, because often it takes, the studies show even under good conditions, so that the pregnancy rate is 70–80% after 2 years. But 2 years, that's quite a long time. And especially when we take into considerations that patients getting older, and here the medium family size, the desired family size is still 3–4 children. So when women start with an age of 35, so then later on they will come to a point where they have abnormal embryos, they have miscarriages, which can also make further complications.
So you believe that the time to pregnancy is important, and it is culture specific, right?
Yes, of course.
Can I add culture specific and the economic specific?
Yes, that's why I
said
don't
that.
want to.
Thank you, Barbara. I appreciate your specificity very much. He is my friend, Dr. Hassan, okay?
Okay, Dr.
I
Azai,
think we proceed, Sharif. We proceed.
Dr. Azai, available or we continue? I think we will continue, okay? Now we'll go to the third line of management, which is IVF. Before we do that, I know that in the guidelines, as Amr mentioned, it mentions that alternative second line of management is laparoscopic ovarian delivering. I think Dr. Iman al-Gindi has every statement to add here.
Yes, no harm. As I already mentioned before, we are against drilling. We have seen catastrophes of drilling with all modality of drilling, whether unilateral, bilateral, making one drill, making multiple drill. We have seen cases with premature ovarian insufficiency in Egypt. We don't have donation. So it ended up with a catastrophe. So we should do no harm. And yes, we are against drilling, and we can go smoothly. If it doesn't work from first line letrozole, we go for second line, which is gonadotropin, and then if it doesn't work, we go to ART. So we don't have intermediate drilling station.
Okay. Now we'll go to controlled ovarian stimulation, and is still a role agonist protocol in patients with PCOS, Dr. Yasser Al-Kassar?
No, Sharif. I
No.
think there is no rule for agonist now.
Okay. So we can easily say that antagonist protocol is the gold standard, as we will mention at the end as an IFRI statement. Now, do you believe that freeze all for all PCOS patients could be a policy? Dr. Barbara.
Well, it's the safest way for those patients, because even for 2 reasons. So one reason, if we just trigger with an GnRH agonist, we know all about the severe luteolysis and that the chance of pregnancy crashes down. Only you would have to do a very intense luteal phase protocol to counterbalance it. But this is not always feasible and not always working. So, and the transferring embryos, even if you avoid early OHSS, you still have the risk of late OHSS. So we are doing a freeze all for those PCOS patients. Of course, PCOS is not like the same like PCOS. I think if you have like a mild form and the patient might be okay, then you still could consider a fresh transfer. But of course, you also would have to decide at the time of egg collection whether you start luteal phase or not. And also, as said, taken into account what kind of trigger you are using.
So we can say freeze all for most, but not for all. I think, as I understand it from your statement, it can be individualized.
Yes.
Yeah, thank you. Dr. Hassan, freeze all for all PCOS patients, or still there is a way for fresh transfers?
I think I agree with Dr. Barbara's answer. It is expressed. Thank you.
So it is almost a freeze all for most, but not for...
Yes. For most. For most.
Again, if we are talking about some economic and logistic problems in our country, Now came the progestin prime stimulation. I think in the last couple of years, there has been a lot of experience in Egypt with progestin prime stimulation, and all of the people are asking, is it the same? Does it affect? Of course, it will be for freeze-all patients, but again, does it affect oocyte quality? Does it affect aneuploidy rates? Does it affect pregnancy rates? We are always asking about the effect and also about the protocol. And even from the attendee, we had a couple of questions regarding progestin prime stimulation. We'll start with Dr. Emmanuel Gindi. Please, your experience with progestin prime stimulation.
Well, we know there have been severe deficiency of antagonists in the market, and we were obliged to go for antagonists. So we tried it on a very big scale, and actually we didn't see, of course, with freeze-all, and we didn't see any difference from the data we have reviewed. Actually, I think it was comparable to our previous cycle using antagonist. I don't have any comment about this or have seen any actually any difference. I use specifically, I use dydrogesterone twice per day, starting from day 2 to 3 of the cycle in cases of PCOS till the day of trigger. This is what we use.
Dr. Nihal, are you with us? Dr. Nihal Adil?
Yes, Dr. Sharif.
I want to ask about the oocyte quality comparing progestin prime stimulation and antagonist protocol. Did you notice anything regarding oocyte quality or embryo development?
We didn't make a statistical analysis to prove what I'm going to say, but the quality of oocytes in case of progestin prime stimulation is slightly different, and more poor quality was retrieved when the patients were stimulated with progestin prime stimulation versus stimulation with antagonist protocol. A very high number of oocytes were observed with a high and condensed granular cytoplasm with different central condensation of which may reflect that the organelle is affected in the cytoplasmic of these oocytes. Poor oocyte quality, the embryo quality in compared to this quality of oocytes, which is not that good. The pregnancy rate, we didn't make a statistical analysis to show the results of the pregnancy rate regarding to progestin primed versus the antagonist protocol. But the quality of oocyte is by evidence, and the observation in our lab is affected by this stimulation protocol, and many different parameters were associated with poor quality of oocytes.
But can I object? So can I disagree with this statement? Because I mean, we are having the pleasure to work with Professor Barish Atta, who has a vast experience of progestin prime stimulation, and they lately published a review paper together with Dr. Erkan Kalafat in RBM Online, and the outcomes are the same. I mean, it's a nice approach. It's cost effective because it's not that expensive. And in the end, the outcome, of course, you'll have to do a freeze-all because you cannot do a fresh transfer. But there are no impacts regarding pregnancy rates, live birth rates, and so on. So I think you would have, please have a look at also outside your lab at other publications. So I think just to have a look and see something different or different opinions compared to your own experience.
Actually,
a new approach. So the optimization of this, it is a new approach, and that's a new stimulation protocol. So optimization of this protocol may be not reached, and the optimum protocol.
Maybe may I have a comment, please?
Okay.
Well, you know, upon talking oocyte quality, maybe to be more specific, Dr. Nihal, what about let's speak about something solid, like, for example, plastulation rate, plus to cystic quality. Because, you know, in something like oocyte quality, granular cytoplasm or dark cytoplasm or whatever, sometimes there is no correlation between this and fertilization rate or embryo quality. The issue is to check for plastulation rate, plast quality, pregnancy, live birth rate. This is one part of the story. The second part, about maybe the dose. People are using very high doses of progesterone, valuable form of progesterone. This might explain the probably what you see in some of the cases. But if we standardize the dose and the preparation, I don't think you will see a difference.
Actually, Dr. Iman, regarding the solid KPIs, I looked at the pilot study that we did in our lab regarding pregnancy rate in the PCOS patients, and there is a comparable pregnancy rates in PCOS patients between progestin primed and antagonist protocol. So as you said, when you have solid data, solid parameter like pregnancy rate, it is okay. There have been two recently published meta-analyses, one in the archives in just November 2023, including more than 2,000 PCOS patients, and the other one in the frontiers, 2,300 patients. All are PCO patients, comparable embryologic outcome, comparable aneuploidy, and comparable pregnancy rate. There have been few reports that aneuploidy may be increased in responders, especially more than 38 years old. But these are all, it was just few studies with small number of patients. But bigger studies with larger number of patients, meta-analysis, especially in PCOS patients, very promising results. And I think it may offer great help to our patients regarding the logistic factors and the financial aspects too. Again, a controversial issue. PCOS patients is to be stimulated only by FSH, either urinary or rec FSH. All we need HMG activity, HMG or recombinant LH. May I start with Dr. Barbara?
Well, I mean, nowadays we are having shortage of menopure. I think it's the same most likely in Egypt. So because they didn't have, they had problems with producing. So we are stimulating often with recombinant FSH. And then depending when we see that the progesterone levels are remaining extremely low, then we might even add some recombinant LH, because FSH is making LH receptors. So, and we feel like when the progesterone levels are too low, also we have a problem regarding the oocyte maturation rate. But we don't have like a preferred policy, so usually we make it age dependent. So younger patients are stimulated with recombinant FSH, and a bit advanced age with HMG, or now with recombinant with Pergoveris.
Dr. Barbara, I have noticed from the charts that you shared with us regarding the stimulation that you monitor the FSH level during induction. Can you share with us what are the satisfactory level that above which you feel that the receptors are totally activated and you don't need to increase the dose?
I mean, I think there are like two interesting aspects. So one aspect is that if you give patients with the same patient's characteristics, the same dosage often, and when you measure FSH, serum FSH levels, they can have huge variety, which is very interesting, because obviously some patients metabolize it differently. Some need more, some need less. So usually we aim to have like an FSH level around 20. We don't, I mean, we are analyzing our data. Of course, often we are now aiming at a study really to go more precisely regarding the FSH levels. We aim approximately 20. For sure, if a patient has like an FSH level of 40, and when she starts to respond, we are decreasing rapidly, and initially we started with steps like 25 units, which is kind of homeopathic. So now often we are reducing like 75 or even 150 units. And then, of course, as the FSH will slowly also decline, and follicles keep growing.
So you monitor FSH routinely on your...
Yes. And also remember what is the graph what I have been showing. So the shift of receptors. So in the end, when a follicle reach a size of 15, 14, 15, 16 millimeter, there are not many FSH receptors left. It's mainly LH receptors, so it's almost a waste. It will not be effective anymore.
Can I ask you, Barbara, two things?
Yes.
First, you measure FSH certain time after the injection? After
This would be the ideal scenario, but of course our patients are not always coming in at the same time. I mean, we have like fixed more or less or recommended injection time, so that we are injecting the or that we ask the patients to inject the gonadotropins in the evening and the antagonist in the morning. So usually when they inject like between 6 and 8 p.m. and we see them back around like 10, then usually it's like 12, 14 hours what we have the FSH level. So of course it's declining already.
Yeah, 12 hours after the gonadotropin injection. You measure
Yes.
FSH 12 hours.
12, 14.
And for, like you said, the LH receptor are expressed on the medium-sized and larger follicles. Rather than measuring FSH, you would like to measure LH, for example, or?
No, we don't measure LH.
So your measurement or monitoring mainly to keep the FSH within the 20-something, right?
Yes, right.
Thanks so much.
Dr. Hassan?
Yes.
Yes, LH activity, do you believe it from the beginning? Do you believe in it or not in PCOS patients in antagonist protocol? Do you give it from the beginning or after for the second half of stimulation, please?
I'll go what Professor Dr. Barbara said. In the first half of the cycle, you need FSH. In the second half of the cycle, you need LH. So the better protocol in PCOS patient is the sequential protocol. So you give FSH in the start, till the follicle is 14, it started to have LH receptors. Then you give HMG. This will decrease the number of follicles. It avoids progesterone rise and it decreases hyperstimulation.
I recall.
And we published this also.
Yes, I know. Yes, yes. I recall a discussion between you and me, I think it was few years ago, about cases with extreme AMH, very high AMH levels.
Yes.
And I think you advised me I may increase the dose at these very high AMH levels, or I may add LH. So can you please share your insight with us, please?
Let us ask our friend first, Dr. Barbara.
Dr.
What do you
Barbara.
do in AMH, which is 9, 10, 11? Do you do something different?
No. I mean, we adjust the starting dosage to the BMI. Of course, we are hesitant and we monitor the patient closely. So with an extremely high AMH and a patient who is not too obese, I would start most likely cautiously, like with 150 units, but I would see her back after like 4 or 5 days to see what's going on. And also in this sense, measuring the estradiol level is very nice because sometimes you see the follicle still small, but you see that the estradiol is already going up. So, and then I think it's a different situation when you see estradiol is going up. Then you see that, I mean, follicle growth will come. However, if you see the follicles are still extremely small and your estradiol stays with like 50, then you'll have to top up.
How many days they take to fly to start responding? 9, 10 on that dose?
Well, we in such a case, as mentioned, I would see her back after 4 or 5 days. I prefer to see them back a bit earlier, just that we can react on what we are seeing.
Okay. Dr. Iman, do you give LH to your patients, HMG or REC LH, PCOS patients?
Yes, I give
With very high MH?
two things. First, I give combination. For me, recombinant FSH alone, it gives severe OHSS. So I always make the combination. I give one ampoule, start with the ordinary dose, 150, 75 recombinant FSH, and 75 whatever the monopure if present now, whatever the present HMG or whatever. This is what I do, and in this way, I end with a reasonable number of oocytes. This is the one question. The second, yeah, regarding high AMH. I don't, there have been trend or suggestions that we start with a high dose. No, I don't do this. I start like Barbara said, exactly. I start with the low dose and I see them very carefully. And I know that they, as long as there is even if the E2 level is low, but they are going up very slowly, and I observe the response, and I observe the rising E2, I observe the starting triple endometrium, I know that I'm in the right way. But if they take too many time, I can start the dose safely, and I go there thereafter. But there is no need to start with the high dose from the early beginning, because this might be catastrophic.
Regarding agonist trigger, Dr. Yasser, what is the dose you use in agonist trigger patients? 2, 3,
Sharif,
especially
I have a comment for the previous question. For high AMH, usually I counsel the patient that I will do freeze all. So I am not afraid about any problem will occur. Usually, if I have high AMH like 9 or more, I usually say that I will freeze all. So this may make me more comfortable during my stimulation protocol. Second, for your question about the agonist trigger in obese PCOS, yes? Obese.
yes, obese.
In obese, usually I give 3 ampule, not 2 ampule. I give 3. For the lean, I give 2 ampule, but for obese, I give 3. And sometimes I give 4, because sometimes I have a female above 100. So I think that we can increase the dose safely, 3 or 4 according to the weight.
Dr. Barbara, you said you have a lot of a high percentage of your patients are overweight and obese. So what dose of agonist trigger do you use, please?
Usually it's 0.3. And then we ask him to even inject it intramuscularly. So to the deltoideus muscle. And as said, if we have a history of low maturity and patient was in a previous cycle not too bloated, so we have a little bit an idea, we might add a slow, slight dosage, low dosage of ACT.
Okay. Regarding prophylaxis against ovarian hyperstimulation, we are talking about agonist trigger and freeze all policy. Okay. Do we need any extra adjuvants, right? The cabergoline, like post retrieval antagonist dosage, or for example, aromatase inhibitors post retrieval, or you only depend on just agonist trigger, freeze all, and that's it?
No, we give, well, often we give Dustinex and Cetrotide and sometimes even additionally Femara to bring them down. However, also this might be a bit country specific, because we feel like when a patient, you know, during the night she develops like abdominal pain, she goes to an emergency room. We feel like there's no experience for many gynaes in an emergency room, that they have no clue how to deal with the situation. And sometimes then the patients get even worse. So we are a bit overprotective maybe. So it might be different in a different setting where you can rely on where the patient is going to in case of a complication or pain, because we are just a day clinic, so we don't have a hospital in our backup where people know how to deal with ovarian hyperstimulation patients.
So you depend on the combined approach to
Yes.
your prophylaxis. Dr. Hassan, I think you published something about the combined approach in prophylaxis against ovarian hyperstimulation syndrome. Yes.
Yes, I think it's very effective, and I think we all have to learn it. It's just as have been said before. Immediately after you pick the oocytes, you give letrozole 2 per day for 5 days with dufastone, with antagonist, as Dr. Barber said, or with oral contraceptive pills. We measured the progesterone after 5 days. It drops to below 400, and that's it. The patient will not suffer anymore, and everything is fine. And we call this the switch off.
Dr. Iman.
I do the same, and actually, I'm very keen that the patient will not go to any hospital, especially
Yes,
these cases. They take it to the ICU immediately. So my concern, actually, in addition to my, for the patient to go for hospitals. So I go for every protective procedure. I go for Dostenex with antagonist, if available, with letrozole. And also, maybe I give anticoagulant. I am very careful for hydration because the patient problem is closing her mouth. So dehydration worsens the condition, or these together will eradicate OHSS completely.
I'm happy that you all mentioned Dostenex because Professor Hassan Ali and myself presented in ASRM, I think more than 6 or 7 years ago, about usage of Dostenex, early administration of the Dostenex, when not on the trigger day, but 2 days before the trigger day, and it was even more effective than the later administration.
And it was published.
Yes, and it was published later on. Yes, and it was published later on. As we see from the guidelines, it says that we don't use routinely. It's not recommended to routinely use the exogenous recombinant LH, but it didn't mention what about the non-routine, what is about the individualization. So I think we covered this point. Now we'll shift to something completely different, adolescent PCOS. We have some issues regarding diagnosis and counseling, which is, I think, very important because this is the first time the patient is diagnosed and we need counseling for her and her family. Of course, they are worried about everything and then how to manage. A diagnosis, may I go to Dr. Iman?
Yeah, like Dr. Riham said, it's a regular cycle. The classic is a regular cycle and hyperandrogenism, and we can't count on neither ultrasound nor AMH. Okay, and of course, many of them, they come in adolescence and what pick their attention, getting some weight gain. So we know it. Again, soft counseling. Our mission is to make stressless counseling and for the girl and for her parents. Okay. Lifestyle, of course, modification is very important. I stressed on the necessity of doing exercise, having any diet regulation she likes, no restriction for any specific thing, to keep it for a while. If it works, okay. If not, depending on her presentation, if it is a regular cycle or hirsutism. If it's a regular cycle, she can take safely progesterone 10 to 12 days for regular withdrawal. If hirsutism, my first line of treatment for hirsutism, of course, after measurement of the hormones, is to give oral contraceptive pills, especially those with a special lowering effect on testosterone. This is, I think, what I do. Again, reassurance and rest and stressless guidance.
The good thing about Dr. Iman is she's always worried about the psychological impact of PCOS on patients. She's very, she stresses on this point all the time. Dr. Hassan, adolescent PCOS, I know you have an interest of this subgroup of patients for a long time.
Thank you very much, Sharif. I think the most important point is to avoid overdiagnosis.
Avoid, sorry,
Overdiagnosis.
Overdiagnosis, yes.
Because currently the definition of adolescence is from 10 years, not from puberty. So the access will need 2 years to mature. So after puberty, you don't diagnose PCOS in adolescents except after 2 years from puberty. Okay?
And the management?
This is very important.
Yes.
This is very important. And as Iman said, the management depends on the symptoms. So if she's coming with obesity, don't talk about hirsutism. If she's coming with hirsutism, don't talk about obesity. Just address the point. As regards hirsutism, the only definitive treatment of hirsutism is physical. This is the result of several years of practice. And what we are doing actually is to prolong the periods between physical. We cannot treat hirsutism medically. So
Yes.
you're just prolonging the duration between physical. This is a statement I learned in 20 years. Whatever you do, you will need physical, and what you do is to prolong the periods between physical. So if she's doing lasers, you give pills to prolong, not to treat. You cannot treat it. You cannot treat it. You have to kill the patients to treat hirsutism. Yes, very difficult. So
I'm sorry for interruption, Dr. Hassan. I'm sorry for interruption, but Dr. Barbara, now it's past midnight, and we missed her sleep time, so she wants to say goodbye for all of us.
thank you very much. Thank you
Yes,
very much. And
apologies really, but I'm 2 hours
thank you.
already
We'll
more.
see you soon
So,
in Egypt with
yes.
Christophers and Alexia.
Yes. Thank you. It was
Thank
a
you very
pleasure,
much.
and
Thank you.
sorry
Thank
for
you.
Thank you.
just
Thank
leaving
you.
Good night.
Thank you.
Thank you.
Bye.
Night. Thank you.
Okay.
Sorry for
So
interruption.
that was it.
Okay, yes, counseling in adolescents. What do you stress on?
Professor Hassan said the main word. I think it's a very good statement. Don't overdiagnose, because any female, young female with irregular menses, usually they
Yes.
say you have PCOS. This is a very big problem. So I have to be sure of the diagnosis by ultrasound and symptoms, clinical presentation. I see sometimes we need some investigations to be sure about the androgen level. If we are sure, I think we have to, according to the complaint, as they said, and actually hirsutism is very difficult to be treated. We can regulate combined oral contraceptive pills, I think, is the best for hirsutism and for menstrual regulation. But if there is no hirsutism, I usually resort to progestin, just progestin every 1.5 months or 2 months to regulate the menses. Just all.
We have
If
a question.
if I may add, because you asked me and I didn't answer.
Yes, sure.
Aldactone, spironolactone, in very low doses, can do them both. It can decrease hirsutism and bring the menses, because the side effect of aldactone is bleeding. So she can have menses, and she can lower her testosterone. It's very effective in lowering the manifestation of hyperandrogenemia. Low dose.
I think
25.
aldactone is not present in Egypt nowadays.
I think yes, sir, there is.
It is 25 milligram.
I think from another company, not just spironolactone, but under another trade name, I think.
It is present.
In combination with another thing, I think not alone. If you
Alone.
it's present alone, aldactone alone.
Yes, yes.
I think
Okay.
yes. I think yes. We have some questions from the attendees. A question to Professor Iman. They want you to talk about your novel protocol regarding frozen embryo transfer using by the addition of letrozole for endometrial preparation in FET cases.
Okay, my pleasure. We have to, okay, I will take shortly. I give estradiol first, like HRT. I start with 6 milligram per day from the second or maximum the third day of the cycle. I give it for at least 10 days, and I measure endometrium. I would prefer it endometrium to be 9 millimeter. In literature, yes, it's good from 7 and more, but I would prefer it based on data that the more the endometrium is, could be the higher ongoing pregnancy. So my cutoff for endometrium is 9 millimeter, triple beautiful endometrium. And then I start letrozole 5 milligram. It means 2.5 milligram, one tablet twice per day for 5 days with continuation of estradiol. This is for 5 days only, letrozole. Then I stop letrozole and I start intramuscular progesterone. The only preparation we have in Egypt is 100 milligram per day. So I stop letrozole, I continue with estradiol, and I start progesterone injection, and then I transfer plast. On the 6th day of progesterone supplementation, we go for warming of the plast, and we do the embryo transfer. This is our protocol, and it's published in RBM online, and the full article is available free of charge.
Another question from the floor. regarding can we use letrozole for more than 5 days? Dr. Yasser, can you answer?
I think there is some papers added 7 days or 10 days, but usually I use it for 5 days alone. I didn't for my practice. I didn't find any significance of adding more days of letrozole.
Another question: do we need to add? Can we add metformin without testing for insulin level or HOMA test, Dr. Hassan?
There are papers that that showed that metformin can be beneficial in women with no insulin resistance. And metformin is not an insulin sensitizer issue.
I know. I believe.
Now you know.
Of course. Okay, I think we took some questions from the floor. Thank you very much, and